So I thought in the overview of the talk I would just sort of share a bit of an understanding about how myeloma is quite a heterogeneous disease. No all myeloma is the same. And we're trying to find ways to better not just diagnose it but monitor it as well, to try and understand how deep a response we're achieving in our patients. And for those things to then lead on to, what is the standard of care today and what sort of future treatments are out there, a lot of which was presented at ASH. Now that's the part that will probably get a bit boring and we might flick through some slides, but we'll try and make sure it's of benefit to everyone. Now the other overview, just in the back of your mind, is we sort of stratify myeloma up into when it's smouldering, when it's newly diagnosed, relapse refractory, and then at the end of the section I was going to talk a bit more about monoclonal antibodies. But I wasn't going to talk to any degree about plasma cell leukemia, the role of allograft, or any of the major consolidation studies. We'll just touch on them briefly. I won't be talking too much about transplant at all. So current situation, as I mentioned, that it's about 10 to 15% of our hematological malignancies and 1% of all cancer, and the average age of a patient is about 70 years old. But there is a third of patients who are in the younger age group as well. And over time, the treatments have evolved for myeloma, starting with the IMiDs like thalidomide and Revlimid, and then moving on to what we call proteasome inhibitors. And that's developed a better kind of overall survival picture for myeloma. But most of that in the past has been realised in the younger age group, mostly, I guess you'd imagine because they had to tolerate the more intensive therapies and they had more reserve. Although, when we look at the databases, you can see that the survival curves are improving quite significantly. So in those 20 years, 42% at 3 years, and now the 2008 update was showing a very good survival pattern in the SEER database at 66% at 3 years, depending on which regimen you got. So a lot of it's, we think, to do with the introduction of these more effective drugs, which are also more tolerable by the older patient groups, and therefore you're getting across the board a better survivorship in myeloma. And some of these more recent data that's been released in America shows that maybe the curve is diverted from its usual trajectory and maybe sort of picking up quite significantly. Still, however, it remains an incurable disease in most instances, characterised by multiple relapses and a lot of variability between patient groups. The cells themselves have a lot of what we call genomic instability, so they have this tendency to mutate frequently, and that accounts for a lot of difference between different subclones of the disease inside your bone marrow, which we'll get onto. What we see when we treat myeloma is that it gets progressively more aggressive as you get sequential relapses. So that's one of the things we struggle with, is that each time it comes back we tend to have to use newer and better agents if they're available to try and gain the same degree of control. And there's a lot of debate going on still about whether we should use all our guns up front, as there's a trend to do in America where they've got access to all the drugs at once, or whether sequential therapy is better. If you use all of your medications or more intensive therapy, you've got the disease when it's at its most sensitive because it's never encountered anything before. You're aiming to get a very long-lasting remission, and you're hoping that because the patient hasn't had treatment, that they'll tolerate the adverse effects better. Whereas in Australia we tend to have more of a sequential therapy approach, mainly because of the way that the drugs are funded and sort of given out to the population, as they're fairly expensive. So we're still not sure which approach is going to show the ultimate benefit in terms of preserving quality of life and getting the best survivorship for patients. And I think one of the good things that Australia does pursue is that it doesn't really make a move or a decision on a drug until it's got good evidence, but there is an inherent sort of delay to therapies coming into our market, which is a problem. One of the other new discoveries is that you can't just consider the plasma cells in isolation. They exist in the bone marrow microenvironment where they get survival signals, and this has become clear across all of sort of blood malignancies. So you've got a lymphoma and a lymph node. They're in the lymph node because that's where they survive best, and they get supporting signals from the other cells in the lymph node, helping them to proliferate and to live longer. So one of the other active areas of research is how are the myeloma cells interacting with the bone cells, particularly these cells called osteoclasts, which are the ones which are responsible for destroying bone and creating these lytic lesions in your skeleton. The myeloma talks to those cells and tells them to be active, and at the same time it receives back survival signals. So this is an area of active research where people are trying to disrupt this benefit of the myeloma cells being in its niche. I guess one of the big ideas to have in your mind is that over time there's clonal evolution in myeloma. Sorry. What do we mean by that? What we mean is that you may start out with a progenitor cell here, and when we apply therapy to that cell, it'll cause other cells to maybe proliferate and to respond and survive better than some of the other ones do. They have a survival advantage, so that over time different clones will emerge in this kind of branching pattern. And as you can see here, this grey one may not persist on, but this yellow one does persist on and goes on to propagate a bit more. We don't really have the ability to analyse subclones in your bone marrows, but overseas and in research it's been shown that as the myeloma changes from being smouldering to more active, and then sometimes even as a leukemia, the actual nature of the clone changes quite significantly as the disease becomes more aggressive. And it's not even so much that things are going in a linear fashion. In reality, you might have a cell here, but it may be mutating off in multiple different directions. And some of these mutations will be going on in the next part of the clone, but some of them will be completely new. If you're going to sort of give a targeted therapy against those mutations, which is where we're trying to head, you really want one that will affect all the cells, so one that will hit all of these kind of blue dots here. Whereas if you just went for one that was going for the yellow ones, you'd get a relatively suboptimal response, because there'd be so much more disease that was left untouched. And if they track clones over time through therapy, this is a patient that's here at diagnosis with these different coloured clones. You can see that as they get sequential therapy, the nature of which clone is dominant is shifting quite markedly. And in the end, after a patient is getting shorter and shorter responses, the actual dominant clone that emerges and causes the biggest problem here at plasma cell leukemia wasn't even present in the initial diagnosis. That's a completely new sort of plasma cell clone. These kind of treatment pathways aren't available to us immediately in Australia, so if someone just starts on Lendex and then carfilzomib, then bortezomib, and then bortezomib with melphalan and prednisolone, that kind of, those drugs are available, but you wouldn't be able to just pick carfilzomib, for example, off the bat. Now you may be wondering, where do the plasma cells come from? And why do they cause these problems? The plasma cell usually starts out its life in the bone marrow, and its main job is to make an immunoglobulin, which is what becomes that M protein which we can follow. The M protein is the product of when the B cell goes into a germinal centre and it's exposed to lots of different other cells which are deciding whether that cell should continue on to make that immunoglobulin. There's a lot of mutations that go around making the IgH molecule, and we find that with those mutations they often carry on into the plasma cell when it becomes abnormal. Now these mutations are called the IgH translocations because they're involved in the immunoglobulin heavy chain. So because that's the whole process of the plasma cell mutating and trying to be different, each plasma cell is trying to be different so it can provide your immune system with something new, we often find that when the plasma cell is abnormal they have mutations in those areas. The other half of them tend to have trisomies of chromosomes, so they have an additional copy of a chromosome. And these are already present, when you are having the phase called MGUS, which is that early, not considered to be myeloma, but it's that early preliminary phase. Later on, you get progression events occurring, and these are mutations that are occurring in important pathways in the cells that are going to, drive the proliferation of those plasma cells to make them more numerous and make them survive more. And then finally, you can get some major events that really dysregulate the cell's growth, like secondary translocations of MYC and major mutational events in significant pathways. I'll skip that one. So one of the ideas, first of all, is that the cells immortalize, or they no longer die. And this is usually to do with abnormalities in the way that the cells are cycling. So a cell will go into a resting phase, and then a signal will come to it from a cell cyclin which says, you can start multiplying now, copy your DNA, and then divide. Now the plasma cells, they've usually got abnormalities of these proteins called cell cyclins, or else some of these other proteins in the nucleus which are telling the cell, go ahead, keep dividing. So that's immortalization. And if we look at the cell cyclins here, 1, 2, and 3, almost all sort of across the board, and all of these different subgroups of myeloma, they usually all have an aberration in their cell cyclin. Some of them are more sort of correlated with some subgroups, but it's very, very common. Another concept is that the genome of the plasma cell is unstable, so it doesn't fix itself properly if it makes a mistake. We call that abnormal DNA repair. So if it gets some damage, or it makes a mistake when it's copying itself, it no longer has the machinery to repair itself. Once you're in that kind of scenario where these proteins here are mutated, you can no longer protect your genome from becoming very abnormal at a quick pace. So you may have heard about P53 mutations. They're fairly sort of significant because the disease then has the capacity to move ahead at a quick rate. So that's what we've covered just now. You've got the myeloma propagating cell at the beginning. It has initial hits to immortalize it, and it has genomic instability, or a tendency to not be able to control its own mutational problems. But then you get additional hits to these different growth pathways. And there are many different ways that a cell can mutate, but you can get extra copies of genes. You can have little point mutations that knock a gene out. We can get changes in the way that the DNA is folded up around proteins which silence genes. Now, our ability to look at your plasma cells has really taken a big jump ahead. We used to just look at the chromosomes, and you could spread them out under a microscope and take a photo, and some bright people in the dark would line them all up and say, well, here they are. Here's 22. This patient's a male with an XY. And you could pick up translocations this way, that being a bit of a gene here was spliced off and put over here. It was a very specialized skill, but not very sensitive. You're just looking at the gross chromosomal changes. We also had the capacity to look at particular translocations here with the IGH locus and cell cyclin D1 by putting probes on those regions of the DNA, and then seeing a color shift when those two particular parts of genes came together when they shouldn't be. So this was a fish study, which was important. But then, in the past decade, there's just been an explosion in the ability to look at the genes and the DNA of the plasma cells. You can look at gene maps of what's being expressed, but then came along what we call sequencing, where they can map the entire DNA, thousands and millions of kilobases of DNA. So you get these colossal volumes of information called next-generation sequencing, where you can see all of the mutations in the plasma cells. And as you can imagine, it creates a lot of problem. You need big computers, and we don't really understand entirely what all of the mutations mean, let alone our ability to target them. But over time, a pattern of mutations build up, in different genes, and then they can correlate those genes with different aspects of the plasma cell's behavior. It's immortalized, it proliferates, it doesn't die. That's called apoptosis. Particular pathways are mutated, and you can get lists of which genes are mutated. So you start to get a picture of, how are these plasma cells different from each other. Now, this would be your current situation, which we talked about at the beginning. You've got either a trisomy or an extra copy of a chromosome, or else one of these translocations. And you're wanting to know what takes a patient from MGUS into myeloma, or even further to myeloma that's going beyond the marrow. One of the advantages we have is that mice, if they have got a biological model of myeloma, they tend to progress quickly. So you can see here, this is a mouse with a monoclonal protein that's developing, but instead of taking years for that to progress, it takes a matter of weeks. And if you mutate some of those important gene pathways you're interested in, you can see that which ones are important in driving the progression of the mouse's disease, and pick out which genes seem to be particularly important in progression of the disease to myeloma. And then you can fill in the gaps about which pathways are important. And it seems to be that in myeloma, there are some very distinct pathways that get dysregulated, and these are the ones that then become candidates for therapy targets. One example which I'll just show you, which I happen to have slides for, was a rare case with a BRAF mutation. This was BRAF mutations are important in melanoma, and this particular patient, this is the RAS-MAPK pathway just here, and the exact molecule they wanted to inhibit was this one here called BRAF. But essentially a signal here goes through the set of proteins and leads to a signal coming into the cell to proliferate. This patient was aged 60 years, had this translocation, which is a risk marker for adverse outcome, has a series of aggressive therapies, but in 3 months since their autograft, which is typically a bad sign, paraprotein jumped from 0 to 54 and the light chains zoomed up, became hypercalcemic, and had plasma cells in the bone marrow, but also these extramedullary plasma cells, and they found that this mutation was present in the BRAF protein. So when they gave the patient an inhibitor for BRAF, I don't know if you can see this bottom corner here, but these yellow hot areas on the PET-CT scan, they all resolved down here. It's just a proof of principle, really, that you can treat very, very specific mutations in some of these patients and get a significant outcome. And this is, I think, a diffusion-weighted MRI scan which shows the resolution of these lesions as well. Here's another patient. Before and after treatment with the inhibitor, that's a bit of a close-up for you. So that large deposit there that's in the rib cage is gone, as well as a smaller one here and this one here in the mediastinum. This is fairly abnormal dysregulated myeloma, and you can tell that because it's grown out of the marrow, gone into the tissues. And here's another patient, had the BRAF mutation identified early on in the course, but it wasn't until later on, after multiple lines of therapy, that they decided they had to treat it with verapamil. And this, soft tissue plasmacytoma goes down, as well as the protein and the light chains there. So it's just the idea, really, the concept that maybe we can personalise medicine even for plasma cell disorders if we can find the mutations through this process of sequencing the genes and seeing which ones are abnormal. The other way we stratify myeloma is you've probably heard of the international staging system. It's only based on two indices. One is your beta-2 microglobulin, and the other one's your albumin. For some reason, beta-2 microglobulin seems to capture the tumour bulk, the effect it has on your kidneys, and also on the immune system. And the albumin, which is produced by your liver, is low if there's a lot of plasma cells around because of the suppression of its production. If you have low serum beta-2 microglobulin and a good serum albumin, you're considered stage 1. If you've got a high serum beta-2 microglobulin, you're stage 3. And if you're neither of those two, you're considered stage 2. And you can see that your survival can be stratified based on which stage you're at. These are survival curves of patients that have gone through large trials where they've collated all of those trials, and you can, the rule seems to apply that you can separate these populations out. If you add in those mutations which I mentioned before, the translocations, you can start making models where you can stratify the patients out even more based on how many adverse lesions they are. So there's a cumulative effect of having multiple bad mutations on your myeloma. So if you've got 3 adverse lesions, very aggressive disease. If you've got very few, your survival is better. When you combine the two, you get even more separation of populations. So these are ways in which trials can try and stratify the myeloma patients and saying, well, what risk group do we put these patients in? Now, this is an ugly slide for a reason that there's far too many trials out there for us to throw our arms around. But the main message about this slide is that in standard therapy, we've gone from having doublet regimens to now triplet regimens, the most common in Australia being Velcade, cyclophosphamide and dexamethasone. And we always saw a large jump up in survivorship once Velcade was introduced, or indeed Revlimid. So the cumulative complete and very good response rates would be up significantly and whenever you saw the Velcade or the V added in. In America, they also tried, this was an influential study called the Evolution Study, where they tried to add in Velcade, cyclophosphamide, lenalidomide and dexamethasone, and they found that they were starting to lose some of the benefit of trying to push extra drugs in because of toxicity. So that's why VCD became, one of the reasons why it became a fairly well-accepted regimen. If a patient wasn't going to be transplant eligible, they'd use melphalan sometimes, or VMP with prednisone. And the other common regimen in America was Revlimid and dexamethasone. In the Mayo Clinic, they seem to stratify out their patients based on their mutational risks, where they have a trisomy and they're transplant eligible. They may kick off just with Revlimid and dexamethasone, collect stem cells. They won't necessarily transplant up front, but they'll continue on. Whereas if you have these translocations, they'll use cyclophosphamide, Velcade and dexamethasone, transplant you, and then use some form of consolidation. Translocation 414, same thing, and then at least a minimum of 1 year of Velcade-based maintenance therapy. Whereas these more aggressive regimens, they throw in Revlimid and Velcade together, transplant you, and then have very aggressive maintenance for at least a year. It's one of the challenges we face in Australia is we don't have access to the same degree of maintenance therapy, and as I'll show you, that's significant now because trials are showing that really maintenance therapy will deepen your level of response. We have to get as much Velcade as we can on the PBS, and that can sometimes be a struggle. If you're not eligible for transplant, then Revlimid and dexamethasone is often favoured because you tend to often be in an elderly population, or else the intensity of the Velcade cyclodex is backed off perhaps to weekly. And there is still an attempt to use maintenance therapy, particularly for the more aggressive lesions. Now, this trial was fairly influential in Europe, and we often look at it in terms of whether it informs us to whether we should give maintenance therapy. But the induction cycles weren't really comparable. This was vincristine, Adriamycin and dex against Adriamycin, Velcade and dex, followed by harvest, followed by transplant, and then either thalidomide maintenance for 2 years or Velcade for 2 years. It's a whole lot of drug, very hard to get your hands on it, but it's becoming common overseas. As you can see, it's hard to go with thalidomide for 2 years. Most people have dropped out. We struggle to get people through thalidomide for 1 year, but the tolerability of bortezomib is much better, in spite of the peripheral neuropathy that you've been hearing about today. The curves do separate out in terms of survival, with your likelihood of death being 25% less, so that's the hazard ratio. Your overall survival is better if you're in the arm with the Velcade as opposed to the thalidomide. And although the induction cycles are different, it probably does argue for not just the benefit of Velcade in induction, but also over the maintenance period. And it also shows that Velcade is better than thalidomide in particularly high-risk subgroups, so translocation 414 and deletion 17p. So I'll probably skip that. Now, if we think about maintenance, going back to those clonal diagrams, what we're hoping is to be able to put the disease into a state of indolence. If we can't completely eradicate it, we're trying to suppress it, but not encourage it to become resistant. That's the whole problem in our minds about if we're exposing the residual disease to drug, are we just encouraging it to proliferate and become more aggressive? Ideally, we'd be able to say, well, this is the clone which has got a better prognosis, and this is got the worst prognosis. We should try and target the worst prognosis subpart of the disease if we can't eradicate all of it. Interestingly, in the UK, when they looked at was thalidomide maintenance worthwhile, they found that it didn't do anything with favourable FISH mutations, but if you had unfavourable disease, it didn't seem to offer you anything. In fact, it was a bit worse. So we don't always know about what we should do with thalidomide, but that's commonly what we have on offer after you've had a transplant. I just include this trial because it opens up the idea of consolidation, which is again something that we're not particularly practicing at the moment. But patients were randomised between either Velcade Thal-Dex or just Thal-Dex, had a double transplant, which is very hard to endure, so they were well-selected patients. And then they had further consolidation cycles afterwards, followed by maintenance dexamethasone. And the main finding here was that they were able to show that after the transplant, they only had 15% of patients in what was considered a complete response. But with the consolidation, they were able to increase that quite significantly. So there was some additional benefit, they thought, of remaining, continuing on with some fairly intensive therapy after transplant. Now, in terms of whether you should just have 1 or 2 transplants, that's really been a bit difficult to push onto a patient because it's a fairly difficult thing to go through. But there is some data that if you're in one of the higher risk groups, a double transplant will give you a significant survival benefit. So that's a patient with 2 adverse variables, so those sort of being a stage 3 disease or having multiple mutations. And the main message being that we want to get the best response we can, and if you get a complete response, as far as we're able to assess it, you tend to survive better. If you never achieve a complete response, you're sort of got an intermediate prognosis. Whereas if you achieve it and then lose it, that's really suggestive that disease is progressing through and your outcomes are not as good. Plasma cells less than 5% in the marrow, eradication of your protein and inability to detect it by immunofixation in the trophine and as well. So that's a stringent CR. I'll just talk a bit later on about how we really need to be able to assess that to a deeper level, because there's still a lot of disease even at that stage. So this is sort of data based on the total therapy regime. This guy Bart Barlogi in Arkansas, he's the guy that kind of throws the whole kitchen sink at his patients. You can see here the induction regime is murderous. This was back in the days when we used to give VAD and then more chemo, double transplantation, then more consolidation cycles and maintenance interferon. So there is some data from total therapy 2 and 3 that his curves do eventually flatten out, and the question about whether he may have cured some patients, but it's a lot of treatment to subject yourself to. So some of the problems, achieving a CR does not account for the biological heterogeneity, so the difference between and inside those clones, and the rates of clonal evolution that we see, or the emergence of myeloma resistance that it gets from being in that microenvironment. Our definition of CR is inadequate, so there's a definition of CR. But you always have residual tumour present, the myeloma progenitor cells that we can't quite get our hands on. Even if you're immunofixation negative, we know that your 3-year progression-free survival is only going to be 50%. So that's even patients in CR. And you can get a deeper level of appreciation of CR if you do some immunophenotypical flow cytometry, which I'll show you some graphs of. But we want to try and get down to the lowest level, which is probably a molecular-based CR, an ability for us to try and detect tumour DNA in the marrow or not. And the importance there of maintaining a CR for the best outcomes.